Christopher Regan today, who's one of our interventional cardiologists in the section, give his talk on antiplatelet therapy. Go ahead, Christopher.
Okay, thank you, Karthik. So today we're going to talk about antiplatelet therapy. So as part of our discussion today, first we're going to review some basics of platelet physiology, why they're important and why antiplatelet therapy is necessary. And then we're going to talk about the various antiplatelet agents, starting out with aspirin. Then we're going to move on to the P2Y12 inhibitors, Clopidogrel, ticagrelor, and prasugrel. We're going to talk very briefly about Kagalore, which is a parenterally administered adenosine diphosphate analog. We're going to talk a little bit about GP2B3A inhibitors. We're going to spend some more time on the optimal duration of dual antiplatelet therapy post-PCI. There's a lot of data on this and a lot to discuss here. And then we're also going to talk a little bit about patients who are in need of both antiplatelet therapy as well as anticoagulation.
Christopher, when you're ready, would you mind sharing your screen, please?
It says that I am sharing.
Yeah, I can see his screen, Rob.
Okay, thank you.
Okay. Can everyone else see? We're all set?
Yes, I can see, so I'm assuming everybody can.
Yeah,
I can see it.
Thank you. So for platelets, obviously they're essential for primary hemostasis and also the repair of vascular endothelium. But they also form and extend atherosclerotic plaques, which is important in what we're doing. And they're also a source of inflammatory mediators, which are important contributors to atherothrombosis. So I'm going to go over sort of a descriptive of platelet activation, and then I'm going to show some diagrams too, which go over the same process. So essentially, for platelet activation, we have vessel injury, which can be plaque rupture, erosion, or fissure, which exposes collagen and von Willebrand's fracture to the bloodstream and to platelets. So inactivated platelets bind to collagen through their platelet receptors, which then results in the release of activating factors, which include adenosine diphosphate, thromboxane A2, as well as thrombin. So these factors enhance the interaction among adherent platelets and then further activate and recruit other circulating platelets to change them from inactive platelets to activated platelets. And then platelet activation by these mediators then is the final pathway for conversion of the glycoprotein 2B3A receptor into its active form, which binds fibrinogen, which then leads to platelet aggregation and thrombus formation. So this is a graphic of this here. So this is a close-up here of the bloodstream or of a blood vessel with a atherosclerotic plaque. So here we have the atherosclerotic plaque here. This is the vessel wall here in gray, and then this is the bloodstream. So we have plaque rupture, erosion, or fissure. Somehow the contents of the necrotic core are exposed to the bloodstream. Non-activated platelets are drawn to this. They bind to collagen and von Willebrand's factor here, and they become activated. So these platelets secrete thromboxane A2, adenosine diphosphate, and thrombin. So when the thromboxane A2 is secreted, it binds to inactivated platelets through the thromboxane receptor. Aspirin, the first antiplatelet agent that we're going to discuss, irreversibly acetylates COX-1 and prevents this binding of thromboxane, so prevents platelets from becoming activated through this pathway. The P2Y12 inhibitors, Clopidogrel, Prasugrel, ticagrelor, and Kagalore, all inhibit the P2Y12 receptor from binding adenosine diphosphate. And then Vorpaxar, which we're not really going to discuss today, inhibits the ability of the PAR1 receptor on non-activated platelets to bind thrombin. So once these platelets do become activated, the final common pathway, as I mentioned briefly here, is for the glycoprotein 2B3A receptor to bind fibrinogen, and this is inhibited by 2B3A receptors, abciximab, eptifibatide, and tirofiban. But if it's not inhibited, this glycoprotein 2B3A receptor binds to fibrinogen, which then which then binds other platelets and actually forms thrombus. So we're going to talk a lot about these various agents and how they prevent platelets from becoming activated. So we're going to begin with aspirin. So as I just said, the antithrombotic properties of aspirin are due to the irreversible acetylation of the platelet COX-1 enzyme, which then prevents the generation of thromboxane A2 and thromboxane A2-induced platelet aggregation. It can only be reversed through the production of new platelets because it's a irreversible acetylation. Aspirin is the bedrock of all antiplatelet therapy, and all previous studies of new antiplatelet agents, the P2Y12 inhibitors, were done in patients who were on aspirin. So why is aspirin the bedrock of antiplatelet therapy? So we'll begin with secondary prevention. So in patients who have had a previous myocardial infarction, so we're talking about secondary prevention here, patients who are treated with aspirin, antiplatelet therapy here, versus control have significantly decreased rates of recurrent MI, non-fatal stroke, vascular stroke, and vascular death, and any death. So this is the reason that we use aspirin for the prevention of vascular events. Now, I will point out that very importantly, this was a meta-analysis performed in 2002. So these were primarily studies that were performed in the 1990s. So this is the basis of what we do right now, although we'll discuss why in some ways that's changing, but it is based on data from a couple of decades ago. And then this is a second meta-analysis and systematic review looking at more than 50,000 patients, again, published in 2006, so mostly from the 90s and the early 2000s, but looked at the hazards of aspirin discontinuation in various patients. So you can see that the rate of vascular events were increased in those patients who discontinued aspirin. The rates were elevated in patients with prior coronary disease, stable coronary disease, and CABG, but the rates of vascular events were particularly increased in those patients who had undergone previous coronary artery stenting. So these were patients, again, this is secondary prevention, patients who were taken off or discontinued aspirin for some reason, had a higher rate of vascular events when that was done so. But again, older data from the 90s and the early 2000s, but the basis of a lot of what we've done for a number of decades here. So this is secondary prevention. In primary prevention, we have new data, and the recommendations have just only recently changed. So the new recommendation from the US Preventive Task Force just last month, I believe, recommended against initiating low-dose aspirin use for primary prevention of cardiovascular disease in adults age greater 60 or older. So this is in contraindication to the previous recommendation that came out in 2016, which did recommend that, or did say that aspirin could be used. It now recommends against using low-dose aspirin. As I mentioned, this data, or this recommendation, just came out last month, so it has not been published yet, but this is the current recommendation, which you and your patients may have read about in the New York Times. And then also it said that the decision to initiate low-dose aspirin for primary prevention in patients 40 to 59 years old who have a 10% or greater 10-year CVD risk should be an individual one. So it's important to mention that it's not that aspirin is not beneficial, that it does not prevent MI and stroke, but in the setting of other well-controlled risk factors. So well-controlled lipids, well-controlled blood pressure, not overweight, the benefit is relatively small and is very similar to the risk of bleeding. So as I mentioned before, this was a change. These are new recommendations that just came out, and they are based mostly on these 3 studies, which came out over the last 5 years or so. So the ARRIVE study looked at moderate risk patients who did not have diabetes. There was no decrease in events in patients treated for primary prevention with aspirin and similar bleeding rates. The ASCEND trial looked at patients with diabetes, but no history of heart disease, and event rates and bleeding rates were similar. And then the Aspirin trial actually looked at otherwise healthy patients who were age 65 or older, and actually found higher all-cause mortality with aspirin. And this was primarily due to cancer-related deaths. This was an unexpected finding, and the authors of this study did caution that, but overall not a very robust endorsement, certainly, of aspirin and primary prevention. So the recommendations for aspirin and primary prevention have changed based upon all these 3 randomized trials. I will mention quickly the current trial. So this in regards to the appropriate dosing of aspirin. So this was a 2x2 factorial study that actually looked at patients with who had undergone PCI, and it looked at either standard dose or double dose clopidogrel, 75 or 150 milligrams, and then looked at aspirin, 81 milligrams versus 325. And for aspirin, 325 or 81, there was no significant difference between those 2 doses. And so that's why 81 milligrams of aspirin is considered sufficient. And that's based primarily on the current OASIS trial here. So next we'll move on to the P2Y12 receptor blockers. So the first one is clopidogrel. This is still the most commonly used P2Y12 inhibitor in the United States. It is a thienopyridine. Clopidogrel is a prodrug. So the tablet that patients put in their mouths actually has no active metabolite in it. 85% of what is taken in is actually is what is absorbed is actually hydrolyzed to an inactive metabolite. So obviously only 15% is converted to an active metabolite through the CYP2C19 system in the liver. And we'll discuss why that's important in just a moment here. So a brief mention of the dosing. So for post-PCI, we recommend 600 milligrams, followed by 75 milligrams daily. That's the typical dose. You give 600 to start out for a faster onset of peak drug and greater platelet inhibition. I will also mention too, in the setting of fibrinolysis, obviously not something that we do very often, but does come up on test. Only P2Y12 inhibitor in the setting of fibrinolysis, and the dosing, which does come up on tests as well, is 300 milligrams followed by 75 milligrams a day. So the basis for using clopidogrel is the CURE trial. So this was patients with unstable angina, the majority of who underwent PCI, and those patients were treated with placebo, but as I mentioned before, were on aspirin and then were given clopidogrel in addition to aspirin, and there was a 20% relative risk reduction in the rate of vascular events with clopidogrel. So this is the initial study, which is the basis for our use of clopidogrel in the treatment of coronary artery disease and post-PCI. So clopidogrel is a prodrug, and so must be converted to the active metabolite through the liver in the CYP450 system with part of 2C19. So everyone has two alleles, 2C19 alleles for the conversion of clopidogrel into the active metabolite. So it is possible for you to have a loss of function allele. So for those patients who have one normal functioning allele and one loss of function allele, they're deemed intermediate metabolizers. And then those patients who have two loss of function alleles are poor metabolizers and have no ability to convert clopidogrel from a prodrug to the active metabolite. So intermediate metabolizers, depending on the population, is about 25–27% of patients, and then the poor metabolizers around 2 to 3% of all patients. So patients who are intermediate or poor metabolizers have reduced ability to produce the active metabolite. They have reduced inhibition of the ADP-induced platelet aggregation, and they do have increased post-PCI ischemic events. So we can test for this. We can do it here at Yale New Haven, but the issue has become, who should we test? Most of the data does not demonstrate a benefit to doing this testing, even though post-PCI ischemic events are increased in those patients who are intermediate or poor metabolizers, most likely because stent thrombosis, which is what we're really trying to prevent in those patients on clopidogrel, is a complex process which has many factors. So stents have become, increasingly better. Patients are most often on aspirin, and there's a lot of other factors. So this loss of function allele is not necessarily the only factor which goes into an increased incidence of stent thrombosis. So the only trial that has been positive was one that came out a couple of years ago, 2018, in the New England Journal of Medicine, termed Popular Genetics. So this looked at a STEMI population. So patients were randomized to standard treatment, which is either prasugrel or ticagrelor, or a genotype-guided therapy group. So patients had a STEMI and then were tested, and if they were found to be intermediate or poor metabolizers of clopidogrel, they were treated with prasugrel or ticagrelor. If they were found to be normal metabolizers, then they were given clopidogrel. And so for the primary outcome, which was a combined endpoint of vascular events, MI, stroke, death, the genotype-guided therapy, there were numerically fewer events, which was non-inferior to the standard treatment group, and there was significantly less bleeding with genotype-guided therapy. But as I said, this was the only positive trial that occurred in a STEMI population. There have been all the other studies looking at a group of patients who are at less ischemic risk, so stable coronary disease and STEMIs, did not show benefit. So currently, it is not recommended that genetic testing be performed in order to prevent these events, but could be, in someone who for some reason cannot use prasugrel or ticagrelor, or is going to be on clopidogrel, and you have concern about the risk of stent thrombosis, it is an option to test patients for this loss of function alleles. I also mentioned too that with clopidogrel there is a diminished pharmacodynamic effect in those patients who are treated with proton pump inhibitors, particularly omeprazole. This is generally not clinically important, but is the reason that you get the warnings on Epic when you try to order clopidogrel and people have and are prescribed omeprazole as well. So next we'll move on to second P2Y12 receptor inhibitor, which is prasugrel. So it's also a thionopyridine, just like clopidogrel, but it has a more rapid onset of action, superior active metabolite generation, resulting in less response variability, and a very low prevalence of non-responsiveness. So it does not depend upon the 2C19 system for generation of its active metabolite, and it does result in greater inhibition of ADP-induced platelet aggregation compared to clopidogrel. So the randomized study that looked at prasugrel versus clopidogrel is called the Triton timmy 38 study. And this did show that in those patients who mostly were post-PCI, who were, and it was all a ACS population, all ACS population did show a significantly decreased combined endpoint, which was vascular events with the use of clopidogrel as with the use of prasugrel as compared to clopidogrel. All these patients were on aspirin, and this did come at the cost of some increased bleeding, but significantly decreased rate of vascular events, again in the ACS population. So prasugrel has some contraindications as well as strict and relative. So the relative contraindications are those patients who are less than 60 kilograms and greater than 75 years of age. And the strict contraindication is a history of TIA or stroke. And this is due to an increased risk of fatal or intracranial bleeding. Greater than 75 or less than 60 kilograms, you can consider. So the usual dose of prasugrel is a 60 milligram load and then 10 milligrams a day, once a day. In those patients who are low body weight or advanced age, you can consider using 5 milligrams of prasugrel rather than the usual 10 milligrams in order to decrease the risk of bleeding. But in those patients who have a history of TIA or stroke, this medication is not recommended at any dose. There's no benefit in medically managed patients, so these patients should be post-PCI. And the COAST trial actually looked at pre-treating patients with prasugrel. So they came in, had an NSTEMI, and then looked at giving patients prasugrel prior to understanding their coronary anatomy, and there was no benefit to pre-treatment due to an increased risk of bleeding. So it is not recommended that we use prasugrel until the coronary anatomy is known. The second newer P2Y12 inhibitor is ticagrelor. So it is not a thionopyridine, it is this word right here. It's a direct acting P2Y12 inhibitor. It has, just like prasugrel, rapid onset of action, greater level of platelet inhibition as compared to clopidogrel. It also has a more rapid offset of pharmacodynamic action compared with clopidogrel. So the trial, the randomized controlled trial, which looked at ticagrelor versus clopidogrel, was the Plato trial. So just like the Titan timmy 38 study, this was an ACS population, the majority of patients undergoing PCI. Significantly reduction in the cumulative incidence of vascular events with ticagrelor as compared to clopidogrel. These patients were all on aspirin. So the rate of the decrease in vascular events was very similar with ticagrelor as compared to clopidogrel as it was with prasugrel, but there was a mortality benefit with ticagrelor, and so the in these Twilight and timmy 38, which came out at similar times, was increased, and that's seen at Yale New Haven Hospital. So we still mostly use clopidogrel, but ticagrelor is the second most commonly used P2Y12 inhibitor, and the use of prasugrel very limited. So I briefly talk here about the Pegasus Timmy 54 trial. Ticagrelor, the usual dosing regimen is 180 milligram loading dose followed by 90 milligrams twice daily. So clopidogrel and prasugrel are both once daily drugs. So you also may see the 60 milligram of ticagrelor dose used. So this is from the Pegasus Timmy 54 trial. So this is patients who had had an MI within the past 1 to 3 years and were considered at increased vascular risk based upon advanced age, mild chronic kidney disease, multivessel disease, diabetes. And so these patients who had already been treated for 1 year, they were randomized either to placebo, which was, obviously they're getting placebo, but just aspirin, ticagrelor 90 milligrams twice a day, which is the usual dose, or ticagrelor 60 milligrams twice a day. And so the rate of vascular events was decreased with both the 90 milligram and the 60 milligram dose as compared to placebo. But the rate of bleeding was decreased with the 60 milligram dose and similar rate of events. So if you treat your ACS patient with ticagrelor 90 milligrams twice a day for 1 year, after that 1 year period, if you think that continued dual antiplatelet therapy is necessary, you may consider decreasing the dose of ticagrelor down to 60 milligrams twice a day based on this trial here. And we will talk about a little bit about the continuation of dual antiplatelet therapy for more than 1 year in upcoming slides here. So the Plato and Triton were the 2 trials which looked at ticagrelor or prasugrel versus clopidogrel. This is the ISAR REACT trial, which is published in 2019, New England Journal of Medicine, which actually looked at prasugrel versus ticagrelor. So this was an open label trial and looked at patients who are managed post-PCI, post-CABG, and medically. Patients were pre-treated with ticagrelor, which is typical, or were not pre-treated. If they were given prasugrel, they were actually treated with prasugrel once the coronary anatomy was known. Patients were followed for a period of a year, and there was actually a significant decrease in the rate of vascular events with prasugrel as compared to ticagrelor, and there was no significant difference in the rates of bleeding. This trial had a couple of caveats. So like I said, it was an open label trial. Some people have criticized sort of the modest patient numbers, around 4,000, just over 4,000 patients. And there was a significant number of patients who discontinued their ticagrelor. So ticagrelor has the side effect of shortness of breath. Usually this occurs just within a few days after the initiation of the medication, but does result in a number of patients being taken off ticagrelor because of that. And also there is also the fact that it's a BID dosing as compared to once daily for prasugrel. So that may have contributed to those patients who discontinued ticagrelor. But overall, decreased number of events with prasugrel as compared to ticagrelor. And as I mentioned before, because we use ticagrelor in our STEMI population, because we preload, because we can pre-treat with it, and also because in the Plato trial, they did see that there was a decrease in mortality with the use of ticagrelor. So there was a much larger uptake of ticagrelor overall. But based on this trial, and also based on the fact that prasugrel is once daily and is now generic, I do urge you to consider that if for some reason your patient does not tolerate ticagrelor or can't afford it, to consider the use of prasugrel rather than switching to clopidogrel right away. I also will mention too, in the trial, this pragmatic, there are those contraindications to the use of prasugrel. So no one should get prasugrel if they've had a TIA or stroke, but in those patients who are of advanced age or low body weight in this trial were given 5 milligrams once a day. And still there was a decreased rate of events with prasugrel as compared to ticagrelor. I'll briefly talk about Kagalore. So this is a parenterally administered adenosine triphosphate analog. So it has a very short half-life, rapid onset and offset of action, the dose-dependent and predictable pharmacodynamic effects. So essentially, this would be used in the cath lab if either the patients were not treated with, not pretreated or treated with P2Y12 inhibitor, and you are concerned about, the P2Y12 inhibitor inhibition during the time of PCI. This is a very expensive medication. I've never actually used it, but it could be considered for, I think the most common scenario where it's brought up is in the setting of, for example, a STEMI with cardiac arrest, where even if if the patient's intubated, and even if you could get some P2Y12 inhibitor on board, their absorption in the setting of, cardiogenic shock, cardiac arrest is going to be very poor. And so, if you were concerned about ischemic events, you could consider the use of Kagalore, which would just be used in the cath lab or sort of a bridge period before you could were confident that the oral P2Y12 inhibitor had been absorbed. And then we're also going to talk a little bit about glycoprotein 2B3A inhibitors. So as I discussed at the beginning of the talk here, platelet activation induces a conformational change in the glycoprotein 2B3A receptor on platelets, which enhances its ability for fibrinogen, which then binds to other platelets and forms thrombus. So these agents, eptifibatide, tirofiban, and abciximab, all block this. They are very effective in inhibiting platelet aggregation, far more so than the oral antiplatelet agents. So I mentioned the three that we use that are available. Tirofiban is typically the one that we use here. They each have different pharmacodynamic properties, but they are associated with increased bleeding. So we used to use them a little bit more, but the data was limited and does not sort of reflect, those early trials did not really reflect current practice. So ticagrelor, prasugrel were not available. Given the lack of efficacy and increased bleeding in the early ACS trial, we no longer sort of use routine early glycoprotein 2B3A inhibitor administration. So at some points, if patients were considered high risk, or having ongoing ischemia before they got to the cath lab, we would consider, initiating glycoprotein 2B3A inhibitors. We do not do that routinely at all anymore. Because of the new two P2Y12 inhibitors, really we only use glycoprotein 2B3A inhibitors in the cath lab as sort of a bailout strategy. So patients have a STEMI, for example, they've undergone PCI, but there is residual thrombus, whether at the PCI site or more commonly downstream. You could use, and the thrombus burden is significant even with restoration of blood flow. You could consider, a bolus of glycoprotein 2B3A inhibitor, and even, a short infusion. But at some points it was recommended that you use 18 hours of these medications, but really resulted in significant bleeding. So we do not do that anymore. So perhaps in very specific events, we could use a bolus in the cath lab, maybe a short infusion, but we no longer routinely use these medications. So next, I'm going to talk about the optimal duration of dual antiplatelet following PCI. So percutaneous coronary intervention, place a stent in the coronary arteries. The general recommendation is that we use aspirin in addition to one of the other P2Y12 inhibitors. So for acute coronary syndrome, the current recommendation is 1 year, whether it's medical therapy, percutaneous coronary intervention, or cabbage. So in some setting, and occasionally this is sort of in patients who come in with an NSTEMI, referred for cabbage. If they were given P2Y12 inhibitors, they're taken off for cabbage in order to prevent bleeding at the time of cabbage. It is important to actually restart that P2Y12 inhibitor in addition to aspirin. Once they've recovered from their surgery, the risk of bleeding has decreased, and they should be treated with that for the course of 1 year. So that is the current recommendation in acute coronary syndrome. Now, in those patients who have a stable coronary syndrome and undergo PCI, there are multiple trials which demonstrate that 3 months to more commonly 6 months may be sufficient for stable coronary artery disease, especially with second-generation stents. This can be a somewhat confusing topic because we have multiple trials which look at the safety and efficacy of shortening dual antiplatelet therapy following PCI. And then we also have trials which look at lengthening the treatment of dual antiplatelet therapy for more than 1 year. So this can be considered for more than 1 year in patients who have undergone PCI if the risk of bleeding is, the risk of recurrent MI is considered to be greater than the risk of bleeding. So obviously these are individualized decisions, and we'll go through some of the data that can help us, hopefully help us try to make these decisions. So one study that looked at extending dual antiplatelet therapy for more than 1 year was the dapp study. So this looked at patients who were treated post-PCI with for 1 year with mostly Clopidogrel and aspirin. They had no recurrent events, no bleeding events over the course of 12 months. And then they were randomized to placebo, which was just aspirin, versus continued dual antiplatelet therapy. And then they were followed for an additional 18 months to get out to 30 months. And there was a significant decrease in the rate of vascular events in those patients who were continued on dual antiplatelet therapy for more than 1 year post-PCI. But this came at the risk of increased bleeding. Now, I will also point out too that all patients were taken off dual antiplatelet therapy at 30 months, and there was a slight uptick in the number of vascular events that occurred once this was done. So anytime you do take patients off dual antiplatelet therapy, there is a risk of increased vascular events, but the protection that is provided with dual antiplatelet therapy comes at the risk of increased bleeding. So as I mentioned before, this should be an individualized decision. So how do we make this individualized decision? So the authors of this study came up with the dapp score. So a score of greater than 2 is associated with a favorable benefit-risk ratio for prolonged dapp, while a score of less than 2 is associated with an unfavorable risk-benefit ratio. So those things which increase the rate of bleeding is age. So greater than 75 years of age, you get -2 points. So as mentioned before, a positive score is associated with a benefit of extended dual antiplatelet therapy. In those patients who are of advanced age, they get -2 points because of their increased risk of bleeding. And then there's also things which increase your ischemic risk. So ongoing cigarette smoking gets you a point, diabetes, MI presentation, prior PCI or prior MI gets you a point, small stents, first generation drug-eluting stents, which we don't really use, history of CHF or decreased LV function gets you 2 points, and saphenous vein graft PCI also gets you 2 points. So, and when I look at this, one way that I use this is I have patients who unfortunately, are on the younger side in their 40s or even 50s. They have had a STEMI presentation and they continue to smoke, for example. And so at 1 year, these are patients, that I would favor continuing dual antiplatelet therapy beyond 1 year if they've done well on it previously. Whereas other patients, for example, patients with stable coronary disease who are of advanced age, those would be patients that you would want to strongly consider taking off. Risk of bleeding most likely outweighs the ischemic benefit of continued dual antiplatelet therapy. So now that is the extending therapy beyond 1 year and those patients who are post-PCI. And now we're going to look at some of the data that actually looks at decreasing the duration of therapy. So this was the senior trial. And so these were patients who were all greater than 75 years of age, all undergoing PCI. Patients were randomized to to drug-eluting stent versus bare metal stent. In a stable coronary disease, they were treated for 1 month with dual antiplatelet therapy. And then in the setting of acute coronary syndrome, they were treated for a period of 6 months. So there was, so overall MACE was decreased in the drug-eluting stent group. And this was mainly driven by target lesion revascularization right here, and with no significant difference in mortality, MI, or stroke. And so this is also, in addition, is one reason that we really do not use bare metal stents anymore. So drug-eluting stents are significantly better than bare metal stents in terms of target lesion revascularization. And so one argument was that we should use bare metal stents because you could use a shortened duration of dual antiplatelet therapy in those patients who are very high bleeding risk. But this study here demonstrates that even shortening dual antiplatelet therapy to 1 month for stable coronary disease and 6 months for acute coronary syndrome in those patients who are high bleeding risk based on age greater than 75, there was a significant benefit for overall MACE and no significant difference in mortality, stroke, or MI. And there was no significant difference in the bleeding risk in those patients who were treated with bare metal versus drug-eluting stents, but there was a numerical decrease in the rate of stent thrombosis with drug-eluting stents, demonstrating that in those patients who are high bleeding risk, even in ACS, the duration of dual antiplatelet therapy can safely be decreased. So previously we've discussed dual antiplatelet therapy, or extending it beyond 1 year in the setting of acute coronary syndrome or percutaneous coronary intervention. We've also discussed that there's multiple trials showing that 6 months, 3 months, even down to 1 month can be safe. So the next question that has come up is that in the setting of P2Y12 inhibitor use, especially ticagrelor or prasugrel, aspirin does not really add a lot of ischemic benefit in addition to those medications. And it does increase your risk of bleeding due to its direct, because it does increase the rates of primarily GI bleeding. So the STOP DAPP trial looked at patients who were post-PCI, and this looked at 1 month of DAPP, which is primarily aspirin and clopidogrel. So 1 month of DAPP and then 11 months of just clopidogrel, no aspirin, versus 12 months of DAPP. And this did demonstrate a decreased rate of vascular events, which was a significant, a decreased rate of a composite endpoint, which include vascular events as well as bleeding. This was driven primarily by the difference in bleeding, but overall the primary endpoint, which was a composite of vascular events and bleeding, was decreased in those patients who were treated with clopidogrel and aspirin for 1 month, followed by just 11 months of clopidogrel versus 12 months of dual antiplatelet therapy. Now, this was a post-PCI population, both stable coronary disease as well as acute coronary syndrome. The authors did do a STOP DAPP ACS trial, which was all acute coronary syndrome. 56% of those patients were STEMI. This was not this trial here, I didn't show it, but and in that they did not meet their primary endpoint. So in those patients who are at increased ischemic risk based on their presentation, the use of clopidogrel alone may not be best. But in those patients who are lower ischemic risk and higher bleeding risk, the use of 1 month of dapp followed by 12 months of clopidogrel in this trial here could be beneficial. Smart Choice trial looked at a Korean population. Similar study looked at dual antiplatelet therapy for a period of 1 year versus 3 months of dual antiplatelet therapy, primarily clopidogrel and aspirin, and then 9 months of just clopidogrel, and decreased rate of events with vascular events with the, so no significant difference in the rate of events with just clopidogrel as compared to the dual antiplatelet therapy for a period of 12 months, with significantly less bleeding in the clopidogrel alone group. So those two trials, Smart Choice and the Stop dapp, looked at treatment with clopidogrel alone versus dual antiplatelet therapy. So the Global Leaders trial actually looked at treating patients for 1 month with dual antiplatelet therapy of aspirin and ticagrelor. And then the experimental group was 1 month aspirin ticagrelor and then 23 months of just ticagrelor. And then the control group was aspirin and ticagrelor for 1 year and then 1 year of just aspirin. So the primary endpoint for this study was all-cause mortality and recurrent MI. So it did not meet its primary endpoint, so overall a negative trial in this sort of unique, certainly unique antiplatelet regimen, but there was decreased bleeding with the ticagrelor, but overall a negative trial which did not show mortality benefit with the use of just ticagrelor. So then they looked at a similar idea in the Twilight study. So this looked at 3 months of ticagrelor aspirin. So all patients were treated for 3 months with ticagrelor aspirin, no events, no bleeding in those 3 months. Then the control group, the control group was continued on aspirin ticagrelor for a period of a year. In the experimental group, they were taken off aspirin and just treated with ticagrelor. And this showed that the rates of vascular events, non-inferiority with vascular events, so no increase in vascular events with the treatment of just ticagrelor for the 9 months after 3 months of dual antiplatelet therapy versus and there was a significant decrease in the rates of bleeding. So if this was not an ACS population, this was a post-PCI population, but complex coronary disease. So you could consider, after 3 months of aspirin ticagrelor in patients with complex coronary disease, you could consider the use of just ticagrelor with no aspirin versus in order to decrease the risk of bleeding at least in this trial, looking at more than 7,000 patients, did not show an increase in vascular events. So I'm going to talk about antiplatelet therapy and anticoagulation for a little bit here. So 5 to 10% of patients who were undergoing PCI require anticoagulation, whether that's for atrial fibrillation or DVT-PE, and it may be up to 20% of patients presenting with acute coronary syndrome may eventually develop atrial fibrillation. So the combination of aspirin, clopidogrel, and warfarin, which was deemed triple therapy, substantially increases the risk of bleeding as compared to dual antiplatelet therapy alone or anticoagulation alone, up to a 2 to 3-fold increase. Aspirin and clopidogrel is inferior to warfarin for stroke prevention, so you can't really just use aspirin and Plavix unless you may consider it if you're scoring these one. In general, aspirin Plavix is inferior to anticoagulation for stroke prevention. And then triple therapy, especially with ticagrelor and prasugrel, is not recommended given the increased bleeding risk. So the first trial, which looked at actually taking away the aspirin, looked at a group of patients with coronary artery disease who were post-PCI, and they were treated with, there was a triple therapy group with aspirin, Plavix, and warfarin, and then there was the experimental group was warfarin and primarily Plavix with the dropping of the aspirin, and did show a substantial decrease, as I mentioned before, in the rates of bleeding with the taking away of aspirin. There was not an increased rate of vascular events, recurrent MI or stroke with this, but certainly a small trial and was underpowered for the demonstration of vascular events, but was the first trial that clearly showed that the rate of bleeding was decreased with the withdrawal of aspirin. So there have since been multiple trials, 4 primarily, which looked at the NOACs versus aspirin with dual antiplatelet therapy, and looked at and withdrawing the aspirin. So there's multiple trials. I chose this one, the Augustus trial, because this one did show a significantly decreased rate of bleeding with apixaban versus warfarin, and also a significantly decreased risk of bleeding with the withdrawal of aspirin versus the use of aspirin. So overall, with antiplatelet therapy and anticoagulation, dual antiplatelet therapy with clopidogrel and a direct oral anticoagulant is generally recommended. In those patients who are considered high risk for bleeding, or are considered high ischemic risk, you may consider triple therapy, so aspirin, Plavix, and a NOAC for 1 month if their bleeding risk is considered low. In the setting of stable coronary disease post-PCI, you should convert to anticoagulation alone after 6 months and after 1 year in acute coronary syndrome. So NOAC is recommended over warfarin. Dropping of the aspirin is generally recommended with one of the P2Y12 inhibitors, primarily clopidogrel. Most of the studies were done with clopidogrel. You could consider using ticagrelor, but that really has not been well studied, and prasugrel should generally be avoided. It is recommended. I have 2 quick studies to end this end the talk here. So one is the AFIRE trial. So this looked at patients who were with coronary artery disease, who were post-PCI or post-CABG. So after 1 year of antiplatelet therapy, along with and had a need for anticoagulation. After 1 year, patients were randomized to either combination therapy, which is rivaroxaban and either P2Y12 inhibitor or aspirin, or they were randomized to rivaroxaban alone, and it did show a decreased rate. So there were decreased rate of events in the rivaroxaban alone grouping, and this was non-inferior compared to combination therapy, with a significant decrease in the rates of bleeding. So in those patients with coronary artery disease who require anticoagulation after a period of 1 year from their event, generally it's recommended that the anticoagulation alone, without aspirin, without a P2Y12 inhibitor, could strongly be considered to decrease the rate of bleeding. And then the final thing I was going to talk about a little bit is the idea of pretreatment in acute coronary syndrome. So in patients who present with ACS before, not STEMI, but for NSTEMI, before they go to the cath lab, there has been a consideration that perhaps we should give people, in addition to aspirin, we should load them with their P2Y12 inhibitor, whether that's clopidogrel or ticagrelor, not prasugrel, before they go to the cath lab, in order, with the idea being that having some P2Y12 inhibitor on board at the time of stent placement could be beneficial for preventing sort of peri-PCI MI. In this meta-analysis trials, including some that we discussed, the ACOAST trial, the ISAR REACT trial, did not show a benefit with pretreatment. So In general, it is not recommended that pretreatment in the setting of NSTEMI be used prior to knowing the coronary anatomy. So patients can be loaded even on the table right before they're going to undergo PCI, if that's the decision. And mostly this is because of the increased rate of bleeding in those patients who are pre-treated for acute coronary syndrome and then end up either that medical therapy is needed or they have a coronary artery disease was not the cause of their elevated troponin, or they go on to CABG. So pre-treatment in most cases is now generally not recommended. So that's my talk for today, and I will take any questions if people have them.
That was a tremendous talk, Christopher. It is a really complicated topic, and I think you covered all the aspects really well. Let me see if there are any questions in the chat here.
Hey, Karthik and Steve, I have a question.
Yes.
Christopher, I don't think there's much data on completely aspirin-free angioplasty out there, but in your kind of review of this topic, do you have any opinion on whether that's possible or in the future?
I did not really come across it, as you mentioned. So there was not a lot of discussion of, withdrawal of aspirin and just using P2Y12 inhibitor. So even, in the Twilight study, Stop Dapp, Smart Choice, and the Tycho study, which I didn't mention, which is also using Kagalore, those patients were all treated for either 1 or 3 months with aspirin, as well as a P2Y12 inhibitor before withdrawing the aspirin. In the setting of anticoagulation, the triple therapy with aspirin, P2Y12 inhibitor, and anticoagulation is recommended in what they call the peri-PCI period. So while those patients are in the hospital and maybe up to 1 week, they should get aspirin before the aspirin is taken away, and they're just continued with a P2Y12 inhibitor and anticoagulation. So that's really the closest that I saw to aspirin-free, which was not aspirin-free. They were given aspirin before PCI, and on that day, and then for a day or two, at least in the hospital, I did not see aspirin alone, or no aspirin at all for PCI.
Okay, thanks.
So Christopher, I have a question about stable CAD. So most of the trials, obviously, that you outlined for both Platotrial and ticagrelor are in the ACS population. A lot of the dapp duration trials have obviously included stable angina patients as well while evaluating these potent P2Y12 agents. But what is your opinion about stable angina patients? Because what I observe around me and what the data suggests as well is that there's a lot of use of potent P2Y12 agents in stable CAD population as well. And we do have some small trial data from from Ephesus trial, although non-US, but in the Europe, which showed that they are equivalent. So what has been your practice, and what is your suggestion for stable patients?
So some of the some data that we do have, is the Twilight trial. So that did look at the idea was to gather sort of a complex coronary patient group, but were stable patients just with complex coronary disease. And the decision was to made that they needed ticagrelor because of their complex disease. They were treated for those 3 months. With dual antiplatelet therapy, ticagrelor and aspirin, and then taking them off aspirin and just using the ticagrelor. So I think that is a reasonable option. This is probably the one trial that sort of looks at that. We do in complex coronary disease use some of the more potent P2Y12 inhibitors, which I think can definitely be considered. And after 3 months, you could possibly consider withdrawing the aspirin in order to decrease the increased risk of bleeding, which is associated with those the newer P2Y12 inhibitors as compared to clopidogrel.
You also discussed about the ISAR React, 5 trial and Prasugrel and ticagrelor, and obviously one is generic and one is not. Have you changed your practice on the basis of that? Because there have been criticisms of the trial. The effect on the difference between ticagrelor and Prasugrel seemed to be more than clopidogrel versus placebo from the older trials. So people had some concerns about that. And also, obviously, in the end-STEMI population, there's no preload with the Prasugrel, even within the trial, as opposed to ticagrelor. But the data still is pretty compelling that it seems equivalent, if not better, for sure. So what is your suggestion?
Yeah, it has changed my practice. So the pretreatment thing, that should have been a benefit. You would consider that may have been a benefit for ticagrelor, so you could preload patients, whereas Prasugrel you had to wait, but showed no benefit there. So that was one of the reasons that really pretreatment is not really recommended. And what I have been doing is I have been in patients who are not pretreated, who are given aspirin.
In the end-STEMI population, though.
Even in an end-STEMI population, still pretreatment, the data for it is not good, is not strong. So even in an end-STEMI population, if those patients are not pretreated, once I know the coronary anatomy, I have been giving patients Prasugrel on the table. And I think that, there have been some criticisms of that ISAR React trial, but I think those are the criticisms of the trial, I think are criticisms of ticagrelor. So, there was they said, oh, well, a lot of patients discontinued ticagrelor. Well, they may have discontinued it because of side effects. They may have discontinued it because of the BID dosing, which are reasons that our patients are going to continue to discontinue. So, and I think most importantly, if you are going to take someone off ticagrelor because of price, because of the BID dosing, because of the side effect of shortness of breath, I think our default has been really to move patients to clopidogrel. But I would strongly encourage patients, especially in an ACS population, to consider using Prasugrel instead of going to clopidogrel if you're not too concerned about their bleeding risk and they haven't had stroke or TIA in the past.
That's great, because obviously the forces in the hospital, a lot of people control what is being administered, before the patient comes to the lab. So I think there's definitely a room for change there, given that it's a generic medications, and in clinic I often see patients are not able to afford ticagrelor even now. So I think I've been trying my best to change my practice, but it's not easy, as many of these are preloaded, and then it sort of becomes complicated.
Sure.
The last sort of comment is about real world data. And clopidogrel versus the potent agents, and some of the observational data from Sweetheart Registry and others have shown them to be equivalent in the real world population. Although these registries have older patients than what I enrolled in the trials, but still that's food for thought as well. That in the real world, possibly the effect of ticagrelor and Prasugrel that we envision should be there doesn't seem to be there.
Yeah, so there has in that setting, there has been the concern that perhaps the real benefits of ticagrelor or Prasugrel are really in the very beginning. So we sort of give patients ticagrelor or Prasugrel for a month after their PCI in the setting of end-STEMI, and then we could switch them to clopidogrel. We could decrease their risk of bleeding, and they're sort of outside that high ischemic window when the really potent P2Y12 inhibitor is needed. But the data for doing that sort of de-escalation therapy is not really there, and there's not really a lot of guidance on who we can switch over safely, and what the timing should be, whether it's after 1 month, after 3 months. But that they are working on that. So there are trials which are working on that, and that may be what we do in the future, is sort of treat patients for 1 to 3 months with the ticagrelor and then switch them to Clopidogrel, or maybe we will move more to withdrawing the aspirin and just using one of the one of the ticagrelor or prasugrel on its own. But we need more data on that, on exactly how to do that and what population is safe to do that in.
Awesome. Well, thanks again, Christopher. That was a tremendous presentation and discussion, and I think everybody will go back to the cath lab now and think about these data as they practice.
I appreciate it.
Has any more questions? If not, then we'll get back to work.